Okay, with us today is the director of the Scoliosis and Trauma Center at Texas Plano Presbyterian Hospital and the Texas Back Institute, my good friend, Dr. Isidore Lieberman. Hi, Izzy. How are you today?
I'm very well, Robin. Good to see you again.
Good to see you. We're talking today about Mazor's SpineAssist product, which has been around for a couple years, and you've had a chance to use it in surgery. First of all, just for our viewers that may not be familiar with the SpineAssist, what is the SpineAssist? And I guess it's referred to as a kind of a robot. So what is it exactly?
Right. The SpineAssist is a robotic platform that essentially acts as a guidance system. So you can map out where you need to be on the spine and implant screws, do osteotomies, place cages, whatever it may be, with enhanced efficiency and precision.
And how does it work? Is it a single unit or a couple units?
Yeah.
How does it work?
The device itself is a parallel manipulator, so it's a small device that's about the size of a soda can. It's got two plates, one on top, one on bottom, and in between you've got 6 essentially turnbuckles or motors, so it can move in three-dimensional space. The bottom plate is attached to a reference frame that's a reference to the spine. The top plate has attachments, various different arms to accommodate different tools that you can use. The real magic of the system is not the robot itself. The magic of the system is the software and the preoperative planning that you can go through. To use the robot, you get a preoperative CT scan. That CT scan is uploaded into the computer system, into the software, and in a virtual three-dimensional environment, the surgeon then plans exactly what he wants to do step by step through the operation, where he wants to place pedicle screws, or translaminar screws, or facet screws, where he wants to create osteotomies in the bone, where he wants to place the cages. Once you have that preoperative plan going, you can then take that to the operating room, and the robot facilitates that plan. So it's all done ahead of time. You know exactly what you need to do. The scrub tech team has everything prepared, so it makes for a more efficient operation. And we do not need all the fluoroscopy during surgery, because once we've referenced the spine with an AP and an oblique X-ray, the robot knows where everything is in three-dimensional space, so you just push button A, B, or C and dispatch the robot to the various stations and implant the screw or place the cage or do the osteotomy using the guidance devices of the robot.
That's very clever. I looked at the website and I saw that the SpineAssist has been used in about 630, 640 cases. I'm sure this isn't quite something you'd use in every case, even though I'm sure Mazor would like you to use it on every case. Are there some cases where this is particularly useful for, and if so, what kind of cases would those be?
Yeah, there's a couple issues. First off, we've actually got up to 2,000 cases now.
Great.
So there are a number of centers using it, and we're gaining experience and learning more and more about the subtleties of using this kind of technology, and already looking to the second and third and fourth generations of this technology. There are certain cases that do very well and where this system is very amenable to it, and there are cases that my initial thoughts were going to be that this is the ideal case, but we still have a little ways to go in the development work. Right now, the ideal case is a 1 or 2 level percutaneous lumbar or thoracolumbar fusion, where you can reference, you can implant the screws, you can do everything without all the radiation that you previously had to use. There are a number of good implant systems out there now that you can use percutaneously, and the precision of the robotic system is so good that we really don't have to worry that it's a percutaneous procedure.
Wow, that's excellent.
In the development of this, my initial thoughts were we want the robot to help us with our revision type scenarios, our deformity scenarios, and our tumor scenarios. Now, we have had some limitations, and again, we're still developing this and learning the idiosyncrasies of the system. If you cannot get a good AP and oblique x-ray in the OR, if, for instance, it's a tremendous curve. I've done a couple cerebral palsy cases where the curve has been 100 degrees plus. It's hard to get the right x-ray and for the computer to interpret pixel for pixel and match the virtual image to the intra-op image. So we've had a few limitations there. If you've got someone that's morbidly obese, which is unfortunately a big issue today, you can't get enough penetration with the x-ray, the bony landmarks aren't that prominent on the intraoperative x-rays, that's been a bit of an issue for us. But by and large, those are the two areas. I've been using it for a lot of the revision scoliosis cases where I've got a solid fusion, but we've got to do an osteotomy because of a coronal or sagittal malalignment. I plan the osteotomy preoperatively. I place K-wires through the osteotomy path right through the fusion mass, and then I use those K-wires to guide my burrs, my osteotomes, and everything else to actually affect the osteotomy. So that's where it's really helped in my practice.
Well, Izzy, as always, excellent description, excellent, very reasoned description of how to use the product. Just in closing, I know, by the way, for anyone looking at this video, you can get more information at the Mazor website. But from your experience, would you say this is a great tool if a surgeon is interested in improving their accuracy and certainly reducing the amount of radiation and fluoroscopy in surgery?
Robin, you and I have had the discussion before about radiation, and surgeons have not taken care of themselves. I think it's a huge issue. I do think we have to be much more aware of radiating ourselves during surgery. And with a lot of these minimally invasive procedures, the amount of fluoroscopy radiation use has skyrocketed. So this is a valuable, valuable tool just for our own personal health. The biggest lesson that I learned from using the Mazor technology now has been the preoperative planning. I have learned a lot more about the spine before I even get into the operating room, so I feel that my cases run more efficiently and I'm much more accurate with the cases, and I can anticipate problems ahead of time because I've run through the case beforehand. I give the example to my patients of a pilot flying a plane. Before he even gets into the cockpit, he does his preoperative plan, takes into account the geography, the fuel, the weight, the weather, everything that's going on, plugs it into a program, then goes on board and plugs that program into the computer, and the computer facilitates the flight plan. Well, that's exactly what we're doing. The pilot still flies the plane, the surgeon still does the spine surgery, but we've got our preoperative plan, and the SpineAssist system facilitates that plan for us.
Outstanding. Great summary. Izzy, have a great rest of the day, and thank you for taking a few minutes off to talk to us.
You're very welcome, Robin. Have a great day yourself.
Thank you. Bye-bye.